Well, IgG4 related disease is an orphan disease. There is no drug that is approved by the regulatory agencies for the treatment of IgG4 related disease. So every drug that we use technically is off label. The standard of care for treatment across the world is prednisone or some other type of glucocorticoid. These drugs are cheap, but they have lots of side effects. And particularly for a disease that tends to affect middle-aged to elderly individuals and to target the pancreas, putting patients on steroids is exactly the worst drug to use. So we desperately need other medications that are approved, and presently there are none. One of the medications that is used off-label and appears to be quite effective is a B-cell depleting agent called Rituximab or some other type of B-cell depletion, but that's not approved. And so all the time we run into problems with patients who can't get rituximab or some other type of B-cell depleting therapy because their insurance simply won't cover it. That's true in the United States. It's even more true all around the world, where access to B-cell depleting therapies or other biologic agents targeting B cells are just not accessible to patients. Well, because across the world, steroids are the cornerstone of therapy. There are all types of toxicities. For example, glucose intolerance or diabetes resulting from steroid use, weight gain, elevations in blood pressure, risks of opportunistic infections, skin toxicities, such as acne and hirsutism, neurological, neuropsychiatric problems such as difficulty sleeping, and even more severe in terms of neuropsychiatric symptoms, depression, anxiety, and even frank psychosis can occur in patients treated with steroids. And then there are bone toxicities, particularly osteoporosis and pathological fractures of the spine and the hips. All of these complications result from glucocorticoid therapy. So that's a major challenge that patients face. Oh, that's a tremendous question. Telehealth has an enormous role to play in the treatment of IgG4 related disease. This is a rare disease. Most physicians currently in practice did not learn about this in medical school. It wasn't even recognized as a unique disease entity until about 20 years ago. So there is a great lack of knowledge about this disease in the medical community. That means there is enormous delay in diagnosis. Patients typically have the disease for many months, symptomatic disease for many months, and probably have active disease for years before they're diagnosed. They go from clinician to clinician, from subspecialist to subspecialist, and are given often erroneous diagnoses. Many times they undergo medical procedures such as major surgeries for these misdiagnoses. And if we could bring to bear telehealth on the diagnostic process, that would likely greatly cut down the time to diagnosis and reduce these inappropriate treatments and procedures that patients often undergo. Oh, they're central to these kinds of questions. It's so disheartening to tell a patient that we know what you have and we can treat this effectively, and we're going to treat it with disease with drug X, but then not be able to get drug X. There's already a great deal of mistrust among patients with IgG4-related disease of the medical community stemming from this delay in diagnosis and the misdiagnoses that occur. Then to finally make the right diagnosis for the patient and begin to educate them about the disease, but not be able to have them get the medications that we know are likely to lead to much better outcomes, that is incredibly frustrating. And it all gets back to payers and health systems that will grant patients access or not to these medications. Well, I do believe that over the next couple of years, we are likely to have, for the first time, approved therapies. We have learned a great deal about the pathophysiology, that is, the inner workings, the elements of the immune system that make this disease tick. And we've been able to design targeted therapies to parts of the immune system that will be much better tolerated than steroids and much more effective than steroids. And it is likely that one or two or even more new agents will be approved in the next couple of years. That doesn't mean that patients will automatically have access to them. Access will vary across the world depending on healthcare systems, depending on payer arrangements. And that's why it's so important now to begin thinking about access to ensure that as many patients as possible, once these therapies are approved, will actually have access to them. Well, as the executive chairman of the IgG Forward Foundation, we're delighted to have a collaboration with the Alliance for Patient Access to begin to think proactively now about the issues that many of our patients are going to encounter. And I am very optimistic, given the groundswell of enthusiasm for our foundation and the enthusiasm about working with AFPA, that we're going to be able to greatly reduce these hurdles right out of the gate for so many of our patients.